clinical work, offering clinical supervision, providing education, and conducting research in the field of addictions and mental health, including suicide. And Vicki has been involved in a number of randomised controlled trials examining treatment for addictions and translational research in comorbid mental health and substance use. This is my first meeting with Vicki of the times across Zoom. So I thought I might kick off and hand over to Vicki by first asking her what led you into the drug and alcohol space in psychology, Vicki? If you could just give us a bit of an opener before you kick off your talk. Thanks.
Hi everyone. I ended up in drug and alcohol completely by accident. In my last year of my clinical masters, I didn't really get to choose my clinical placement. So I was forced to do one in drug health, which I wasn't too happy about because we didn't actually have much training in drug and alcohol counselling in our course. So I reluctantly turned up to placement and I loved it. It was just, you'd see everything. You'd see all walks of life, every disorder in the DSM. So it was never boring. And then I thought, this is it. Nothing compares to drug health. So that's how I kind of got into it, purely by accident. And what I was hoping to talk to everyone about today is meth. And then Chris will be talking a bit more about meth and gambling. So basically, if everyone can see that, it's the second most commonly used drug in Australia and worldwide, following cannabis. So it's very prevalent. And everyone can see the screen that I'm sharing. I'll just check before I keep going. Good, excellent. And meth or ice basically was first used to treat ADHD, narcolepsy and obesity. Now, most meth lasts for about 6 to 12 hours and most of it's removed within a day from your body. The challenging thing with meth or ice is that often the withdrawals can last for about 3 months. And this is the difficulty that we pose as clinicians in dealing with this. So usually the first phase lasts for about a week of excessive eating, excessive sleeping and depression. And the second phase is a bit more protracted and can last 3 months and includes things like suicidality, paranoia, depression, lack of motivation. And in our sort of treatment facilities in drug health, in public health, most of our clients attending treatment are unemployed. They've probably been to prison once or twice. Most have got a psychiatric comorbidity as well. And it's usually depression and anxiety, followed by schizophrenia, or your more personality disorders as well are very prevalent. So we tend to only see a certain proportion of meth users, the ones that have struggled to stop on their own. Before I go into the treatment, I thought I'd talk about amphetamines in the brain, just to give you an idea of what it can do to someone's brain. Because amphetamines in general and ice are lipid soluble, they'll pass through your blood-brain barrier very quickly, and they're stimulants. So they stimulate not just the central nervous system, but the peripheral nervous system. And they lead to increases in dopamine mainly, but also other neurotransmitters like serotonin and norepinephrine. So it's the actual increased dopamine which causes psychosis and euphoria. And as you probably know, it's the dopamine that's involved in the reward pathway. So after meth or amphetamines have worn off, you'll see a decrease in dopamine levels, which leads to craving and withdrawal. And down the bottom there, I've just got some pictures of a normal brain and one of a meth user. And as you can see, it often takes about a year, sometimes more, of abstinence before someone's brain can almost return to normal. So the damage is quite pronounced, and I'll talk about the cognitive deficits shortly. We know that long-term use of meth or amphetamines can lead to depression and anxiety. So it's very rare to see a meth client without depression or anxiety. They go hand in hand. The other challenging thing is that it is closely linked with psychosis. So about half of our clients will have transient psychotic symptoms. And 1 in 3 who are hospitalised for psychosis will actually end up developing schizophrenia or bipolar disorder, which is quite alarming. So that's always something to keep in the back of your mind. If you're seeing a meth client and they're starting to display a few symptoms of psychosis, to try and get them treated as quickly as possible, keeping in mind that half the time the symptoms will disappear, but there's also that chance there that they might become permanent. But this, we don't know if the deficits were present before meth or if it's a consequence of meth. The other thing to always keep in mind when you're seeing meth clients is the risk of suicide in this population is enormous. I don't think I've ever seen a meth client who hasn't been severely acutely suicidal. Almost all have had an attempt at some point. And unfortunately, they're more likely to attempt under the influence. And their attempts are likely to be more lethal. Men are more likely to succeed in suiciding if they're using meth. And risk factors of depression and psychotic symptoms mean they're more likely to complete suicide. So with meth clients, we really need to be constantly assessing their suicidality, keeping in mind that while they're under the influence, they're more at risk of harming themselves. Other long-term damage that meth does is we're noticing now with some users that have been using for like 20 years or so that they're starting to get artery disease and strokes and seizure disorders, but we don't know if this is purely because of the meth or whether they had deficits beforehand. And as I mentioned before, the meth causes a huge imbalance in neurotransmitter equilibrium, especially dopamine, and sometimes it can take more than a year of abstinence to normalise. Acute intoxication can be a problem if they're presenting in a clinical setting. Anxiety and depression can sometimes occur in intoxication, even though usually it does cause euphoria and feelings of happiness. You can get pronounced anxiety and depression once they've used quite a bit. And as I mentioned before, they're at huge risk of not only suicide, but risky behaviour and risk of harming other people when they're under the influence. Sometimes if they've taken too much meth, they often present to ED with symptoms resembling heart attack because of the stimulant effect of meth. And often they will think they're having a massive panic attack. And often we see them in ED thinking they're dying of a heart attack. Now, the withdrawals and intoxication are not usually physically dangerous, except in rare instances where you get a case of serotonin syndrome from using too much or basically overdosing on methadone. So we do see that occasionally in the emergency department, but it can be treated. Cognitive deficits with meth users are so prevalent and they make treatment incredibly challenging. So we know from research that long-term use of meth causes deficits in just about every aspect of cognitive functioning, from attention to executive functioning, memory, information processing speed, even your motor skills. So meth seems to sort of damage all aspects of cognition. But the good news is most of the deficits can be reversed once the person's abstinent for a while, but not always. The challenging thing is that the skills that we're deficient in when they're under the influence of meth, so the planning, emotional decision making, flexibility, they're skills that one needs to help them abstain from the drug. So that's often what we're working with. We're often having to do really basic problem solving with these clients. Emotional decision making. So whereas normally with a non-drug using client, you might not need to teach them problem solving, you're often finding with meth clients, you have to get down to basics and teach them impulse control, teach them emotional decision making, teach them problem solving, because these skills kind of go out the window. Now, in terms of treatments, despite the fact that meth use is so prevalent, there still isn't a great deal of research into which treatments work and which don't. We do know that inpatient detoxification alone doesn't work. That in conjunction with counselling is great. But the biggest body of evidence suggesting that CBT works is paramount, that CBT is probably the best treatment for amphetamines or methamphetamines, especially motivational interviewing. So as you would with your gambling clients, always take into account the stages of change and keep in mind that motivation to change waxes and wanes. In terms of medications, unfortunately, there isn't one medication which works. There have been some results from some atypical antidepressants and one anticonvulsant called topiramate, but there isn't one single medication that seems to do the trick. St Vincent's Hospital here in Sydney is running a trial of Lima, which is lisdexamfetamine, which is actually a treatment like Ritalin for ADHD, where they actually give clients a daily dose of Lisdex, but it's actually a double-blind RCT, so clients don't know whether they're getting that or placebo. That trial is currently operating, but it hasn't completed yet, so we don't know if it's effective or not. In terms of psychological treatment, these are kind of the main strategies we'd use. Now, they're all kind of evidence-based, and really the most difficult one is challenging their thoughts about meth. Often these clients will have very interesting beliefs about meth, like, I need it to function, life's boring without meth, I can't handle the cravings, I'll die if I don't use meth. And your role as a clinician really is to identify the irrational thoughts and challenge them, and teach the client to challenge them themselves. Another big part of treatment is identifying triggers for using and relapse, and looking at their self-efficacy, so how confident they are in certain situations that they won't use, and really targeting situations in which their confidence is low and developing an action plan. Cue exposure is also useful, but it can be tricky to implement because you need the client to bring in drug paraphernalia or the drug itself, which is very difficult in a public health setting. But there have been some trials conducted where you use imaginal cue exposure, or they watch videos of cues. Drug refusal skills role play is crucial. A lot of these clients don't have the skills to say no if someone offers them meth. So often we're role playing how to do that correctly in session. But probably the most important component of treatment is to do a proper functional analysis during assessment. So really work out in detail the relationship between meth and gambling with your clients. So does the person gamble only after using meth? Or does the person gamble first and then only use meth once they've won a bit of money, just to work out what is causing the other, and just to see the connections between the gambling and the drug use. And that will help you determine where you go first in treatment. Okay, so they're the evidence-based treatments. These are the treatments of which we currently don't have a lot of evidence for. So acceptance and commitment therapy, there's only one study that compared it to CBT for treating meth, and it found that ACT was no better than CBT. There's little evidence for meth AA groups because mainly they don't really share any outcome data, so we don't know if they work or not. And DBT, there isn't a great deal of evidence that it works with meth users unless the client has borderline personality disorder. So if the client has borderline personality disorder, there's a lot of evidence to show that DBT works. Now, this population, the meth users, are very challenging. You know, they're probably the most difficult to treat, and these are the reasons why comorbidity is the rule rather than the exception. Every single one of them will have some sort of psychiatric comorbidity. You know, whether it's anxiety, depression, gambling. So working out where to start first is really the challenge. A lot of clinicians are frightened of this population because of their high risk of suicide and homicide whilst intoxicated and in withdrawals. Keeping in mind withdrawals could last 3 months. So they are a risky group, and often they present to treatment under the influence, and they could come across as quite aggressive or violent due to the drug effects. This group has a very high dropout rate for treatment. It's very hard to keep them into, you know, 8 sessions of weekly treatment. Their motivation will wax and wane. 1 minute they're super motivated, the next they're not keen at all. So motivational interviewing is really a huge component of treatment with these guys. And our limited medication options makes treatment all that more difficult because a lot of them are looking for a medication to help them to stop. And these are just some treatment guidelines if anyone's interested in more detailed evidence-based treatment for meth. And I can send that out later to everyone if they wanted to have a look at that. But that's all I was going to say today about meth.
Thanks so much, Vicki. That's an amazing overview. I might hand over to Chris. We have had some questions, but we might save them to the end and keep them coming through. We've only got a couple so far. So if anyone's got questions, again, just a reminder to pop them in the chat. And I'll hand over to Chris. Thanks.
Thanks, Kerrie, and thank you, Vicki, for that great overview of you know, meth use and treatment options. So yeah, so Kerrie is right. Back in my undergrad days, I did do pharmacology as my other major, as well as psychology. It's not as interesting as it sounds. It basically involves having lots of little bits of tissue that you drop drops of drugs in and see how the tissue contracts. So it's incredibly dull doing that for hours on end. But that's back when I learned about drugs. So that's my undergrad was a very long time ago now. But I sort of found, I went to look at some of the research on amphetamine use and gambling. There is a paucity of it. And I think it's part of the reason for that is that a lot of research sort of lumps in all sort of drug and alcohol use together with gambling when they're sort of looking for comorbidities. So very little research has that sort of fine grain sort of look at what different drugs have a relationship with problem gambling. And I think that's really important because, for example, like in our clinic, we've been, you know, I've been there 13 years. The clinic itself has been open, I think, more than 20 years. And we quite frequently see clients who have comorbid stimulant use problems. So as well as methamphetamines, cocaine. We do see people that use marijuana, but it doesn't tend to actually interplay with the gambling so much. And then finally, I think in the time we've been open, we very, very rarely see someone who is an active heroin user who is actually gambling at the same time. Like, it does happen, but it's usually a recovered heroin user that we see as opposed to a current heroin user. So it is actually a lot rarer. So there does seem to be something in particular about stimulant type drugs that have a particular relationship with gambling. So I guess that was why the papers that I selected for us to read, in some ways they're not ideal because the populations they look at are very specific. So one is in college students in the States, one is looking at adolescents. But there's some of the few ones that specifically looked at stimulants. And the first one that looked at college students, so that's the Geisner 2016 paper, they found like really high rates of problem gambling in people who are regular stimulant users. So they found people who are stimulant users were 3 times as likely to have a gambling problem as the students who don't use stimulants. So that's quite a high odds ratio. And what they found is even after they controlled for alcohol use, for gender, for other drug use, they found that there was still this strong relationship between stimulant use in particular and problem gambling. But what I think was really interesting about that study is they also did a 12-month sort of prospective sort of to the study where they looked at people who were already gamblers. And what they found is in people who were already problem gamblers, stimulant use in that 12-month period predicted the sort of losses they had, the debt they were in, and the severity of the gambling symptoms they were seeing otherwise. So it seems that for people who are gamblers already, that stimulant use generally really sort of strongly predicts the degree to which gambling problems persist. Now the second paper, which was the Richard 2019 paper. So I mentioned before that, you know, a lot of studies sort of lump drugs in together. The interesting thing about the college paper is that they sort of lump stimulants in together, and they hypothesized that most of the people that used stimulants in that study were people using sort of prescription stimulants off label. So that's things like ADHD medication like Ritalin and things like that, using that as a recreational drug. Whereas this one that was done in adolescents, they even went even finer grain. So they looked at particular stimulants to see their relationship with gambling. So they sort of split it out into crack cocaine, methamphetamines, and this sort of off-label use of prescription medication. And what they found was, even though there was increased gambling with use of all 3 drugs, that it was in particular methamphetamine and crack cocaine that really caused this major increase in problem gambling, as opposed to the sort of prescription stimulants. So I thought that was really interesting, in that it really sort of shows that that meth and crack cocaine, which isn't the same but has some of the similar effects of what we see in methamphetamines, is really what seems to be driving this relationship between stimulants and problem gambling. So that's sort of what some of the research shows. In terms of our own experience at the clinic, you know, I guess as a gambling counselor, you know, I often get people coming in, as sort of Kerrie noted it earlier on, who do use methamphetamines and other drugs recreationally, on some who use them quite regularly. You know, obviously when they're coming to us for help with their gambling. They're not necessarily coming to us because they want to stop their drug use. But one thing I will say to someone that is, whether it's regular or recreational user of methamphetamines, is if you are using this drug, we can do some good work on your gambling, but while you're on meth, or ice, or whatever term that they choose to use, it's going to be that much harder to stop gambling, because it comes back to, you know, some of those sort of effects that this drug has that Vicki was mentioning before, you know, is that this sort of poor impulse control, this very reward-seeking type behavior that you see when someone is on meth, is going to make it really hard for someone to sort of, you know, take a step back before they put that bet on, take a step back before they put money on the poker machines. And also, in particular, fitting, I guess, with our model of gambling is this idea that often when people take stimulants such as meth or cocaine, they get this sort of this almost feeling of grandiosity, this sort of boosts their confidence. And that can also play into gambling in other ways, because if someone has that boost of the confidence, they think, oh yes, well, I know this horse is definitely going to win, or I'm sure that this sporting team is going to win today. And so that increase in their confidence also makes it harder to resist putting that bet on. So I think, so clinically, and I'm very open with clients about this, it is really difficult for someone to give up on gambling whilst they're using meth. So we do talk a lot very in detail about sort of the interplay between the two. So, it's very different for someone who pretty much is only gambling when they're high. Or do you sort of gamble all the time but worse when you're high? Or are they separate activities? Are you only gambling when you're not using, and then using is something quite distinct? Because they pay a sort of different picture. And I guess as a gambling counselor, what you're going to target is going to be different based on that sort of interplay with their drug use. And I think finally, to come back to also something that Vicki mentioned before, is that one of the things that we use is sort of motivational interviewing. So if someone is coming to us and saying, hey, I really want to stop gambling, but I'm not really prepared to look at my drug use, we sort of take that sort of very sort of open approach and say, well, yeah, that's fine. That's, what I'm here for, to talk about your gambling. But let's see how your drug use is impacting your gambling. So, helping them see that there is a relationship between the two, and that even though they might enjoy their drug use and want to continue with it, that it is going to have a cost in terms of their gambling behavior. And I think having that open dialogue with clients, particularly using that motivational interviewing type technique, is really useful for sort of, I guess, challenging some of those sort of beliefs that clients might hold about these two things being quite separate.
I think I can absolutely agree with you there, Chris. And I think, Vicki, you pointed to it as well, the importance of, I think Vicki used functional analysis, that CBT idea of really understanding, and Chris used the word the interplay. It seems to be so important in determining next steps for treatment. Absolutely agree. I might pop to a couple of questions. Chris, yep, okay, great. Just a bit of a housekeeping one first. A couple of questions around, can we receive the links that were on the presentation, Vicki? I think you mentioned that would be okay. So happy to email those around at the end of the talk. We have a good question here. And I think you mentioned, Vicki, in your talk about schizophrenia and bipolar disorder being comorbidities. And the question is there any current research looking into whether those two conditions came about because of meth use versus whether they perhaps were there previously or, spontaneously? Is there any research to back sort of that clinical presentation, Vicki?
There isn't much to suggest which caused the other, unfortunately. We just know that the two often co-occur, which can make treatment even more challenging, especially if you're trying to do rational sort of thinking with clients who are quite mentally disordered at the time. It's difficult to sort of get them to think about changing their gambling behaviour. So there isn't much to say which causes the other. We just know that they frequently co-occur. I think they found some sort of genetic link in one study, but not much sort of solid link for a genetic link.
Great, thank you. I hope that answers the question. And I guess the next sort of thing, perhaps leading on to that from a schizophrenia perspective, if we look at psychosis and some of the things that we're seeing with meth users, how would you go about as a clinician if that was presenting in front of you, Vicki? What would be your sort of guidance on for us counsellors if that's what we're seeing, whether it's because of, say, withdrawals or actual use? What would that look like, do you think?
Yes, it's always really difficult as a clinician when you're seeing a client who's using meth to work out whether the psychotic symptoms are an effect of the drug itself, the withdrawals, or whether there's an underlying mental illness there. So what you need to do is actually treat it seriously, because we do know that with this particular population, their risk of suicide and homicide is enormous. There's also that risk that the psychotic symptoms might persist long term. So as a clinician, what I would do is really look at their risk of harm to themselves and others, try and get them reviewed by a psychiatrist or a GP if you can, just to make sure they're okay and they're safe. Usually a period of inpatient detoxification can help to work out whether it is drug-induced or whether there's an underlying mental illness. But sometimes you cannot tell, because often the clients will have these withdrawals for 3 months after stopping use, and they will still display psychotic symptoms. So it's really a waiting game, and waiting to see whether the symptoms disappear on their own. If they get worse, obviously get the person urgent psychiatric help, because that's really important. Because there is some evidence to suggest that if you treat the psychotic symptoms early, there's less chance of it becoming permanent. So always be on guard for the psychotic symptoms, assess them regularly, and make sure you get the client appropriate psychiatric care. Sometimes you might need to get them scheduled if they're unsafe, but yeah, always assess regularly. Especially risk to them, harm to themselves and to others, which is very common in ICE users.
And that makes a lot of sense, and probably fits probably most of our models if you're having someone present with sort of high risk type presentation. So that's great, and great sort of layout of what to do. So risk of harm to self and others, psychiatric help, GP, that sounds like a really good step to care. I'm just wondering then if, this is possibly a question just from myself, if I can be selfish for a minute, if those sort of more higher risk symptoms subside and you're looking at more of that second stage, that sort of 3 month, I think you mentioned, or up to 12 months withdrawal type symptoms. I know myself, even as a clinician, I would seek supervision around a client that presented with these, but what advice would you offer if we're seeing like less intense symptoms, but just that, well, perhaps they're not intense, maybe that's a bad assumption of mine, but that sort of the second stage withdrawal symptoms, how would you go about working with a client in that phase?
Lots of education helps. So warning them that these symptoms are completely normal, because it can be very frightening for a client to stop meth and find out that their mental state is actually getting worse. And that's why they often tend to go back to using, because they feel better when they're using. And it's a vicious cycle. So getting them, educating them is probably the most important thing. Telling them it will resolve. So giving them lots of education, saying it will get better, explaining the link between continuing to use and their outcome. And that's probably the biggest challenge of all, is actually trying to encourage them to keep abstaining in the light of a worsening of psychotic symptoms and depressive symptoms and anxiety symptoms. So that's where we really ramp up the depression and anxiety treatment. And it wouldn't be unusual to actually refer clients onto a GP or doctor, and they often will prescribe antidepressants just to get them through that difficult time. Sometimes they'll prescribe antipsychotics or medications to help them with sleep, because sleep goes out the window. So really just giving them hope and letting them know that these symptoms will resolve. Try not to keep using, because it will just prolong this withdrawal period. Lots of encouragement and education, and if you need to, refer them on to a medical professional for medication if they're interested. But also it gives you an opportunity at that point to tackle their anxiety and depression as well. So teaching them lots of strategies to improve their mood, and help them get through that awful withdrawal period, because it is quite awful. And that's where we struggle the most with clients, is actually getting them through that withdrawal period, which can take months, because it's really the withdrawals and the cravings that lead them to keep relapsing continuously.
Yeah, that's quite new knowledge for me, and it sounds quite unique. Just the level of time that you are experiencing, withdrawal from this drug, and I can imagine that, yeah, you would get a lot of relapse in that space. So, super helpful to know that that's the case. Chris, can I swing over to you? There's a question here that I think is a really, really good one and really basic one, but is there any point in seeing a client who's intoxicated?
Who's intoxicated? I think for gambling counseling, I would generally, if we're talking about on stimulants, no.
Yeah.
I wouldn't see, with clients who I have, I guess it's up to own clinicians to make up their own sort of rules with this, but for me, I will say to any client that has an alcohol problem or a drug problem that I will say, will respectfully don't use within 24 hours of coming to your appointment. And if that's something that you find difficult to do, then let's discuss that in more detail because you might need more support. So, you know, for someone, you know, we're not talking about someone having a glass of wine, obviously, with dinner the night before a session. If someone is a regular ice user, yeah, I will ask them, yeah, to make that commitment to at least 24 hours before an appointment. And if they say that they can't do that, then that's when I would think that probably they do need sort of treatment for their drug problem, or their drug use, sorry, either before or simultaneously with their gambling, because otherwise it's going to be too difficult for us to sort of make those sort of gains. That's my personal sort of rule. It wasn't necessarily based on any evidence base, but coming to what Vicky was saying about how the sort of half-life of methamphetamines, it sounds like maybe she can answer this, if 24 hours is sort of a good sort of baseline for that.
Yeah, it usually is, because if they're coming in intoxicated, you know, their thought processes are all over the place. And I don't know if you've ever encountered a client under the influence, but it's very hard to even get them to sit down for 10 minutes, let alone a full session. They can't finish sentences. They're going off on tangents, very hyperactive. And in terms of gambling, you know, they're thinking they're going to win regardless of how much money they put in. They can't problem solve at that point. And any sort of therapy you're doing around that will probably go out the window if they're intoxicated.
Yeah, it makes a lot of sense. And Chris, I've probably come from your schooling in that if someone presents intoxicated, I certainly would end the session, and had to do it, was it as little as 2 weeks ago? I think I spoke to Chris about a client. It wasn't for meth use, but during a session there was some drug use. Interesting, again, in these COVID times, on a phone call, where it would be so different in a face-to-face setting. You're not going to have someone, you know, pull something out and use it, you know, in a clinic. But on a phone call, it did happen, and my response was this, just to respectfully explain that it's going to be difficult to do therapy in this instance. And end the call and rebook for next week. So yeah, it makes a lot of sense. If anyone's got any more questions, please keep them coming. One of the things that I thought might be useful to talk about is just building confidence for clinicians in this area, Vicky, because we do work specifically in gambling counselling. Your discussions and your knowledge is fantastic, and hearing sort of some key points that we can do if someone presents with, you know, risk or, you know, in that second phase. I mean, where would you steer us towards? I mean, education sort of being a really key thing in that second phase. Is there somewhere we could look to for fact sheets for that psychoeducation piece? What would you suggest?
Yeah, there are some great web pages out there, and the treatment guidelines that I've got on the last screen, they are really good at giving education for clinicians. There's basically a treatment guideline that's very detailed, and it's got a lot of information there. New South Wales Health also has some good information on ice, and there's also Cracks in the Ice, if people have seen that webpage. So there's a lot out there that will help. And there are a lot of good sort of pamphlets that you can give clients as well.
I would also recommend, now, I know a lot of people watching are sort of all throughout New South Wales, but the thing is about, you know, a lot of drug and alcohol services in Australia, particularly the publicly available ones, they're very much geographically prescribed. So what I would suggest is really get to know the sort of the teams that are working with drugs and alcohol in your local area, so that you can sort of facilitate that sort of that easy referral pathway if the need be, sort of in both directions. Because often, I'm sure, you know, probably Vicky will agree, is that, you know, probably gambling problems are relatively common in stimulant users. So it's sort of good to have that relationship with your sort of local drug and alcohol service. So at least then also you can say to the clients, because if the clients are sort of reluctant to talk about their drug use, you can sort of say, well, I know the, you know, the counselor there, the psychologist there, this is who you're likely to talk to, or this is the sort of people you like to see. I know them. They're, you know, they're good to work with. It sort of gives the client that, if you've got a good relationship with the client, the fact that you can sort of speak to what that service is likely to be like for them is really going to be helpful for them sort of making that decision to take the next step with their drug use if they need to.
Yeah, I think that's a great point, Chris, especially because it does seem to be one of those presentations that requires, you know, a lot of support. Just thinking around, you know, that, again, sort of talking to new knowledge for me around the withdrawal period of time, you know, keeping up as much support for the client in sort of that 3, 6, 12-month period around even just basic depression, anxiety symptoms where you can get relapse. It makes sense that we're going to use like any multidisciplinary approach would be a good thing to do. So I think that's a great tip. That's all the questions we've had. Perhaps can I swing back up to our panelists and maybe just to do a couple of minutes summary on your thoughts in the area, and then if anything else pops up, I'll jump in on the questions. So maybe, Chris, can we start with you? Would that be okay?
Yeah, sure. And I think the main thing that I would say, and this is from both from my experience and from the literature and talking to, you know, psychologists working in the drug and alcohol sphere, is even though people who use methamphetamines in particular can be really challenging, as sort of Vicky noted before, we also have to be careful against, you know, there's a lot of stigma about ice use in particular. And we have to be careful that that we don't inadvertently sort of take on that stigma that's often out there in the media and in society, and sort of, you know, don't give your client these sort of micro signals. Don't balk. Don't feel anxious when someone says that they use ice, because it's, as Vicky said, it's really common. It's the second most commonly used illicit drug in Australia. It's not, you know, there are obviously, yes, you do have those sort of extreme cases where people can become quite violent and quite aggressive, and we shouldn't ignore that, but we shouldn't stigmatize all ice users, and we shouldn't be afraid to sort of see clients just because they're using ice. It's about putting, I guess, the risk management structures in place, but still being open to seeing clients who are using methamphetamine, some of whom are actually quite functional in pretty much other areas of their life, even if they are at high risk for comorbidities. Some of them may be able to keep down jobs. Some of them may be able to, you know, present outwardly as a seemingly normal person. And so we should be, you know, be very careful about, you know, putting out blank statements about not wanting to work with these sort of people.
Yes, I agree, Chris, that, you know, often we're frightened of this population because of how they're portrayed in the media as violent, aggressive, homicidal, and because of the huge rate of comorbidity in this group, they're very complicated to deal with. So don't give up hope, and try not to sort of portray or let off signals that you're absolutely terrified and don't know what to do with them. The best thing is to have a multidisciplinary approach and involve as many other services as you can. Like we rarely see meth users come in just with meth using. There's always gambling. You know, there's there are eating disorders, there's depression, anxiety, psychosis, which sometimes doesn't resolve. We always are treating this group with a number of other clinicians involved. We're rarely the only service treating them. Often their health is in such a bad state. Some of our chronic users will often not have any teeth left in their mouth because of the long-term ice use. So we're often having to refer them, to dental, to certain other medical services because they're really not well. Dietitians, many of them are chronically underweight and malnourished. So we're always, we don't really treat them on our own. We usually have a whole multidisciplinary service group with them along the way. So don't feel you have to treat everything yourself, because usually this group comes with a multitude of comorbidities. So as Chris said before, do get to know your local drug health service, and I'm sure they'll be more than willing to sort of help you either with counselling or detox or rehab options for the more chronic severe users, and also your mental health team might become an important component of the treatment plan. But don't feel you have to take everything on yourself and do it alone with this group, because the rates of comorbidity are so high that it is a lot for just one service to take on.
Do you mind if I ask you a question as well, Vicki? We've talked a bit about the challenges, but do you have good successes with clients with problems with methamphetamines?
Yeah, look, we have had some success with them, and usually, and that's what keeps us going. It's quite rewarding to have successful cases, and usually we achieve that by having a lot of people on board, because they all have a comorbidity, whether it's medical or psychiatric, and I think we're more likely to do well with them if we involve more people in their treatment plan. In our service, though, we tend to get the more chronic, long-term, highly dependent users, but we also get clients who are social users. They might be uni students or they might be high functioning, but they occasionally use ice or meth. So we do see a variety, and success is possible, and don't give up hope with this group. And usually if you can get past that awful withdrawal period, and give them some confidence, boost their self-efficacy, keep their motivation high, you can do really well with this group.
Great. Well, that was so informative, Vicki. Thank you so much for coming and taking an hour out of your time, and probably a lot more in terms of, the lead up and the admin and the slides. We really appreciate it. And thank you to Chris again for your informative take on all the topics we present, and in this case, bring gambling into those topics. There's also an unnamed and unseen behind the scenes, Harrison. I just wanted to thank him for doing the tech and bringing us all together. And thank you all so much for coming along and attending Journal Club. Chris, did you want to say anything before? Yep.
Yeah, so I just wanted to say, I know I sent an email with the date as the next one set as August 13th, but it's actually been pushed back a week. It's going to be on August 20th. We've got something very special planned. I won't give away too many details now, but be prepared for a very interesting talk between two very knowledgeable old hands in gambling, who I'm sure you will all enjoy to hear speak in 20th of August.
And will that be online, Chris?
That will be online, yes.
Yeah. Okay, great. Okay, well, that ends the talk for today. Thanks again to everyone who attended, and got a couple of minutes left of your hour to grab a coffee, or as I'll be doing, pop down to the children and say, be quiet. They're so loud, and I apologise if you could hear them in the background. Bye, everyone.
Thanks. Bye.
Thanks.